How's it looking? We got pretty much, looks like we might have everybody. So Allison, I don't know if you saw my email. I can share my screen for these report outs if you don't mind facilitating. Is that fine?
Yep, that works.
Let's see if I can get the right screen up here. This one. So, what are you seeing?
It is there. It just needs to be in presenter mode.
Okay, and I keep getting notices that people are in the lobby.
Don't worry about that. We can enter them.
Okay. Let's see. Oh, of course, this is how do I do that in Google? Boy, that was an oversight. I'm used to dealing with
I thought it would have been view.
If you go to the very top of the screen, there should be a slideshow play button, like all the way towards where the K is for your name.
Aha. Thank you. Okay. Now, are you seeing the slides?
Yes.
Yay. Thank you, Eva. So hit it, Allison. It's all yours.
All right. So we have some hardworking subgroups that are going to give just a very brief report out on progress to date, what they're thinking about, what they're talking about, and next steps. So if you could hit the next slide, Kathy, I'll introduce which one this is related to. Okay, so as a reminder, these are the 4. There's 8 in total, but we're starting in the first year with these 4. And the first one is integration of primary care. And go forth, we've got the facilitators with Julie Parker from the Blueprint and Sam Sweet from DMH, and you'll see the members listed. And so I'm going to hand it over to whomever is going to present out for that group.
Hi, it's Christine Wernicke. I'm a member of this working group. Can everyone hear me? Just a thumbs up. Yeah, okay, great. We had a couple meetings and have had some very robust and productive conversations and discussion. And this is a synopsis or synthesis of that conversation. Just note that this has been sort of highly organized and that there was a number of different thoughts and ideas that were put on the table. And this is the really good work of Sam and Julie to help us really narrow in and focus. So the initial goal that's been crafted, and we were very careful about the selection of our words here, is that integrated care results when a team of primary care and mental health providers / clinicians, including peers, community support, and specialty care, work together with patients and or families using a systematic approach to provide patient-centered care. Of note here, language that we landed on and which we spent some time about so people understand is the language of provider and clinicians. Different organizations and through different lenses had very different interpretations of how to use those words. So we included both. What the intention here is to be broadly inclusive of peer support workers, community services and community support, as well as specialty care. So we're talking about licensed providers as well as non-licensed, but all very important providers that are serving the population. One of the notes is that the services and what those services are that are needed are identified by the person served. And we feel that it's part of the role of that group to help identify what those services are that are needed in the continuum of care. Then drilling down further into the SMART goal, beneath that is to create clear and better pathways to access the right level of support needs. So this is a little bit reflective of what's been discussed today, which is even some of us within this work and very close to this work might not know what exists and how to access it. And so improving on that for the patient and providers. And then enhanced patient-centered communication around patient goals, progress, and functioning between mental health services, physical health services, and community. One comment, for example, that was made today around the FQHC model is that the providers that were serving the patient both with physical and medical needs and then mental health and social service needs could document in the same electronic medical record. If that's not possible, what is the where are patient-centered communications happening so that everyone's on the same page in regards to the patient's needs and who's doing what around that patient, so improved communications. We were pleased to have members of other work groups happen to be in our group this time, and so that was really helpful. We recognize that we want to, or maybe soon we should conference with other working groups so that we're sharing those ideas, which I guess we're doing now, and we'll continue to meet to identify additional details around the SMART framework.
Excellent. Thank you, Christine. I think in the interest of time, Kathy, we should just move on to the next one. Integration of pediatric care. We've got Laurel Olmland still out there on her own as facilitator. Take it away, Laurel.
Hi. No, we have a great group. So actually, this just slide listing who's the members. So yeah, thanks for advancing that. So we have, go ahead. Yep. We've met 3 times, which I, in itself, see as a success. We've had a group of people who have been committed, even met during the holiday week, and have had some excellent, robust conversations around pediatric care integration. There are clearly overlaps with primary care integration when it comes to pediatrics, as well as overlaps with impact on workforce development and finance. So we share that interest in wanting to think about how to communicate with the other work groups. What we've focused on, first we started to talk about how can we think about this acute concern around the crisis of children waiting in emergency departments while also trying to take up the broader integration goals of this council. And so we acknowledge that there are members in our subgroup who are parts of other teams who are addressing the acute crisis of kids waiting in emergency departments and wanting to keep that work happening in those realms and then bring that information and coordinate it with our subgroup. So we were able to have our subgroup start to take on the broader goals that I think are charged with under this council. We did talk about, what are the themes that we wanted to make sure we all were aware of to inform our work. And really briefly, those are things like understanding the primary care model, that we want things for all individuals, for those at risk and for those who have identified intense needs, as well as our Vision 2030. And then we've started working on what are the SMART goals that we want to really dive into. We've had a lot of, like I said, great conversations, and what's starting to emerge or rise to the top, if you will, are what you see here, but we're going to continue to refine these and then get into more of the action planning and measures and all of that. So we know we need more humans to meet the social, emotional, mental health needs of children and youth at any point within the children's system of care. So that really does, again, speak to both recruitment, retention, and workforce development, but really wanting to enhance the knowledge, skill set, and coordination across those entities wherever kids are. We also know that there are basic skills that are beneficial for all Vermonters to understand that can contribute to the resiliency of our kids, families, communities, including healthcare providers. So that's another component that we think is an important part of this when it comes to kids. And then we talked about wanting to have a system that's organized to meet families' needs versus figuring out how families can plug into the system. I think this is a constant interest of all of us, but just wanting to keep that at our forefront. and acknowledging that we don't necessarily always need a new shiny thing, but we have some systems that exist that have been successful. We just need the enhancements to really grow those to scale and connect it better. So that's where we're hoping to dive in more. And then throughout that, wanting to make sure that we do have youth and family voices contributing to that systems work. So we will be getting into this a lot more in our next meeting. That's high level. Thanks.
Thank you, Laurel. It's funny, I know people were anxious that they wouldn't have accomplished a lot, but when you get to talking, it sounds like a lot. So that's any validation. Thank you. The next one is integration of funding and alignment of performance measures. And we've got Ina Backus, the Director of Healthcare Reform for AHS, and Steve DeVoe, who is our Director of Quality and Accountability for the Department of Mental Health. So we'll turn it over to one of you.
Awesome. Thank you, Allison. So yeah, we, excuse me, we've been making definitely some incremental progress in our work. Part of that is that I just recently started at the Department of Mental Health in mid-October. So I've been getting up to speed as far as the Mental Health Integration Council as a whole, and specifically our work group as well. So Ina and I have been working on scheduling one-to-one interviews with each of our work group members to really just get an understanding and get more information from their area of expertise and experience about some of the successes as well as challenges and barriers that we have to looking at the different funding streams that currently fund our systems, as well as the performance measures that everybody uses, and thinking strategically about how can we align those in order to better integrate our work as a whole. And then again, also, this is something that Ina and I have been talking about as well, and we haven't necessarily brought this to the working group as a whole, but really thinking about how do we overlay a results-based accountability framework to our work, and really trying to think again strategically about how we hold ourselves accountable for this work, and thinking about, again, how do we measure the integration of the work itself. I will say that the caveat of this slide is that we actually had a whole working group conversation for the first time since I've been in my role today. So we actually identified some next steps as well, one of which is looking at the CCBHC work that's currently happening in the state, and using that as a potential concrete example for us to leverage the expertise of our group and bring those different lenses back to that CCBHC work, specifically around the funding and performance measures. So that was something that came out of our brief discussion today, and I know that everybody was really excited about the fact that we were actually able to have a working conversation and really think again about what are some concrete next steps that we can take. So as far as next steps go, we're going to complete those one-to-one interviews and then collate all the information and data that we gather from those, and then be able to report back out to the working group as well, and then also formulate a working list or draft list of metrics that we can track as far as our own progress, and thinking about again, what sorts of performance-based measures would we really want to see and be able to report out on as far as the integration of work. And I think one last piece that I'll add, which I think was a poignant piece, is really thinking again about who the client or the patient is, and what is their definition of health, and and how would their health be better served by the work that we're doing. So in my mind, I'm thinking about different, not only just the providers, but obviously the patients and the clients themselves, because again, they're ultimately the ones that can see the concrete benefits of this work, from the clinical perspective. So that's a short report out. So thank you.
Great. Thank you, Steve. That's exciting. All right, we have one more, and this is the integration of workforce development. That's facilitated by myself and Kaya Ganguly, who's the Director of Trauma Prevention and Resilience Promotion at the Department of Mental Health. And we have a great mix of folks from medical, insurance, VAWS. And then today we had some members who were able to join us, Kareem from Psychiatric Survivors. We had Stephen Berbecco from United Way. So if you could go to the next slide, Kathy. So we thought about what we'd done in progress, and like Laurel's group, we wanted to highlight that we met 3 times, and we did from the very beginning decide to use an RBA scorecard. Thank you, Emma Harrigan, who helped us. You know, we talked a lot about just how big this was, how big, slightly vague, and feeling like it was hard to wrap your arms around, and just thought RBA, results-based accountability, would help us identify what's an indicator of success and what are some metrics we can monitor to get there. And so we did put together a scorecard. It's in draft form. And thanks to Christine Wernecki, who commented when we did presented on it last time, you know, we did some thinking about, we beforehand said, who are you trying to impact? And we said all Vermonters. So we did take some time in one of our workforce sessions to say who exactly. And we made a more detailed list that included teachers, school nurses, school counselors, EMTs, people a little, you know, not necessarily just going straight to primary care physicians and mental health counselors, but broadening that a bit. So we decided when we first came together and in our RBA scorecard of what are we trying to do, it was get enough workforce who had the skills to provide integrated care, and then make sure that that workforce is supported in their jobs. Those were kind of our 2 main goals. And so for enough workforce, we're looking at cross-training to broaden the skill set of limited staff. And that includes everything from, you know, making sure that EMTs are aware of how to approach somebody who might be in mental health crisis, to a primary care physician being comfortable asking a question about suicidality. With that, it came up, let's take a look at licensing requirements, because we had some really great examples of both people who are unable to get licensed because of what I will call a somewhat rigid system. If you're coming from out of state, having to meet that very perfect mix of credits that you're unlikely to have if you didn't get your education in Vermont, by which the licensing requirements were built. Additionally, are they flexible enough? So Annie Remniciano was talking about, you know, do you have the flexibility when you're in a nursing program or another medical degree programming to add substance use credits and have that count? And how are we setting those licensing requirements up to show how we value integration and making sure that we're offering opportunity for that? And then additionally, in terms of enough workforce, we talked about utilizing peer resources. And I wanted to share, Kareem was able to join our group today, and what I found really fascinating about some of his comments was we were getting him up to speed on what we're trying to do here, which was have providers who can serve someone, you know, in a broad, holistic way. And in a very nice and kind way, I feel like he looked at us with 3 heads, like peer support services see people as human beings, and what they need is what we want to support. Like, what? And so I kind of thought that was interesting, because one of the things that the peer community is working towards in the coming year, they put legislation forward to become peer certified, and that would allow them to bill insurance. And how do we manage what happens to providers once you get into that box? Because I think it's one thing that to have peer support providers who aren't in that Medicaid world and in that billing world, I think it helps probably for you to see people as human beings and treat them for whatever they need. And so just really thinking about when we shift people into boxes of funding, how we can make sure that they can keep a holistic lens. I just really appreciated that viewpoint. And then the last piece is supporting them in their jobs. We have a workforce that's depleted, morally injured, suffering from issues with resiliency. And with Kaya's lens, we're grateful to have her in our group because she does a lot of training on this issue. And it's not just about resilient staff, it's about resilient organizations and setting up a space where people have the support and strengths that they can grab onto. It's not just up to them to pull themselves up. by their bootstraps. And so if you're going to have medical providers who can help people with mental health needs, you need to have medical providers who feel supported in their own well-being to then have something to give and offer and stretch. And so that falls into developing safe trauma-informed work cultures, because it can breed a better understanding of mental health needs. Next steps for us are identifying measures that can be shared across systems to incentivize and monitor integrated workforce development. So I think we talked, it came up a bunch of times in our panel today. How do you, if you build, if you trained a DA workforce to help with the medical side, what's the incentive so that that CFO who works at that organization can fully support that initiative? Because it doesn't, tank the bottom line to be spending a lot of time in that area if you don't have any incentives to support the work. And so that and sharing with each other our integrated workforce models. As I mentioned previously today, there's a lot we didn't know. And some of us have been in the field a long time. So just that alone has been really beneficial. And that is all from us.
Thank you, Allison, for handling that. And thank you. Those are great updates. And I just want to say, I told you so, I told you so. You work groups, you're all doing great stuff. You've been doing a lot of hard work, and it's just so cool to see those slides, because I know they encapsulate just a lot more than what's on those slides. So that's fantastic. So unless, Allison, you have other ideas, we were going to go into our public comment period. Were there any particular questions or follow up on the work group report outs before we jump into that? Doesn't sound like it. It's great. Okay, well then we'll open up the floor to public comment period. And if this format doesn't work for you, please feel free to email me. You can either email me comments, I can have a phone call with you. Lots of people, this is sort of this fishbowl kind of thing. If you're not comfortable with it, we really want the public to feel, and it's awkward because we're online. And so if you have any comments now, I'm going to take notes, and we're also saving the chat. So if you want to enter questions there. And Alexis, I see you've got your hand up.
Yes. So I was wondering if I know I talked about this a while ago in another meeting about the symptoms versus the labeling, because I noticed when I went into the peer, I think a lot of the peers feel safe in the labels, and really to change the system, we really need to have a group or some group in the country or people that are psychiatrists and all that come together and form a symptom model where the symptoms are what we address in the people and the children or whoever. And then as they get better, they move to different symptoms or they move out of symptoms, and then they can eventually go into remission and, not be on medication or whatever. Because I see with the peers, when I worked a little bit with them, that, it's all, and other people outside, because I work with people outside, that it's about their label and it's about their drug. And it's hard for them to get beyond that. And it's hard. That's a hard situation, I find. I just wanted to put that out there. And then the other thing is there's a super conference online about trauma going for free right now that's from worldwide leaders. And I took it about a month ago because they had it free then, and took a lot of notes on trauma. And one thing I came up with, I talked about in the with the pediatric people, were that the idea of like a St. Jude's is really what they have. Like that is the kind of thing that wants to be modeled with the children, maybe in smaller hospitals, you could put beds in there. And I don't know, it's what they're modeling because it's positive, it's creative, it has to do with getting family members together and only in a positive way if you really look at the model and follow them and see how they work. And that's the only things I really want to get out there today. I hope that's enough.
Thank
I
you,
said too
Alexis.
much. I'm sorry. I'm trying not
Nope.
to talk so much.
No, thank you.
You're welcome.
Now, Alexis, I just wanted to make you aware because I really appreciated your point. When we switched over, we being the Department of Mental Health, to payment reform, we were trying to change or ensure that there was a person-centered way to assess folks. And so, yes, a diagnosis is still required to bill Medicaid, but we brought into the fold a child and adolescent needs and strengths assessment and an adult needs and strengths assessment. And the entire purpose of those tools is to say, what are your needs? And it's subjective. You have a clinician helping you determine level of functioning, but any area where you get a need does not equate to a diagnosis. And that's a really big piece of the philosophy. It's to say, you might have in your chart that you have depression or what have you, but right now you also have some level of anxiety, a medical concern, and they're not adding diagnoses to your chart. And you watch those and you approach maybe the trauma, maybe that's your treatment plan, but you also see sleep and all these other things getting better. And it was supposed to get at exactly what you were just talking about.
So that's good. So did they actually doing away with like manic depression, the negative labels themselves? Because I had a friend's daughter get labeled recently, and I know this kid, and I've had to talk to her about how she's not this terrible label because she was starting to get depressed about it. I think that, I think depression or sadness, I mean, the way you word things with children especially will teach us all how they want us to word. I find working with children, they're the amazing ones. And I'll be like, wow, that's really true. Like they know more than we do.
Yeah, they're working on labels. We actually had people with lived experience review the language in the assessment tools, and they put a lot of red lines through a lot of terms to say,
good.
Please
I'm glad to hear that. Because even like the term schizophrenia, that is now considered parts therapy. It's like people disassociate, and they disassociate in different ways, like I did when I had a breakdown. But it's getting better. There's so many different ways to get out of that and get better. If you study like the polyvagal theory and all these other trauma theories that they're presenting right now. But anyway, yeah, I think it's important because it's devastating since I was in the system and away from all my family, how you almost want to die in a situation like that when you have a label where people treat you like that whole thing. I'm not going there. I'm getting into repeating myself. Stop it, Alexis. My son tells me that, Mom, the worst thing you do is repeat yourself.
Thank you, Alexis. We've got someone else with a hand raised. Lori, I think. Mulder.
Yes, I just wanted to jump on that bandwagon about language because I really still feel that the federal government needs to change ED. I think it comes across with such a stigma, and that children participating in meetings about their own educational plans, and they hear, an educational person say, and they qualify with an ED diagnosis, and it's like, there it goes right down the tubes, because it carries such
can we spell
stigma.
that out, Lori? Emotional
That's
disturbance
emotional
or social
disturbance.
emotional disturbance.
Yeah, it has such a negative connotation, and I know that Ann Mook worked so hard on language years ago in our statutes. She tried to change a lot of the language that was used, and I just, for some reason, I just want that one to go away. I just think it carries, if you want to say mental health diagnosis, if you want to say, there's like a myriad of other terms, but it just automatically sets the tone for how you move forward, and it just comes across negative. So I do want to say that I agree with you wholly about changing that language.
Good.
Thank you.
If I could just comment on that to say, I do believe the federal government received quite a bit of public input about terms such as social emotional disturbance. I know there was a group that was looking at that because it's a definition not just for special education, but also within the mental health realm and related to our mental health block grant. I can try to track kind of where that conversation is currently.
That'd be great.
Thank you, Laura.
Thank you.
Who else? If we don't have more public comments, we can end just shy of 15 minutes early. This has been a long haul. We only had the one break, and everybody's really stuck in there very well. So thank you very much. Any other? Well, I guess, Allison, do you agree? Should we wind it up?
I think it's time. Just thank you so much, everyone, and to the panelists. I know some dropped off, but I found that to be their experience to be really beneficial to share.
Yeah, oh, it's tremendous. Yeah. Thank you, everyone. And we'll be in touch with lots of follow-up materials and a link to this recording so that you can hear more, hear it, listen again if you'd like. And any questions, anything, please be in touch. Thank you.
Thank you.
Bye.